involved in caring for children with neurosurgical problems, and we will work very hard to make you feel welcome. There is support, there is knowledge, there is information, there is collegiality, there is friendship, all to be had within the ISPN, and we welcome everybody very warmly. I'm going to turn the program over to Artur Cunha, and he will introduce our very esteemed moderator and our highly accomplished faculty. Thank you all for joining us. Artur, please take it away.
Okay, greetings from the Education Committee of ISPN. Whether it's morning, afternoon, or night, we trust that you're doing well. ISPN is thrilled to present the second webinar of the year, which addresses a topic immense interest to pediatric neurosurgery, Chiari malformation. We are proud to have a world-renowned expert on the board, including Professor José Francisco Salomão from Rio de Janeiro, Brazil, a former president of the Brazilian Society of Pediatric Neurosurgery, Latin America Association of Pediatric Neurosurgery, and, of course, a former president of ISPN, who will serve as the moderator. We have today as faculty Dr. Zulma Spinoza from USA, Dr. Mirna Sobana from Indonesia, Dr. Deepak Gupta and Dr. Kaushik Sil, both from India, and Dr. Girish Solanki from the UK. We urge all of you watching us to join ISPN, as we believe that together we can make a meaningful difference in the lives of children all over the world. So now, without further ado, let's welcome Professor Salomão to kick off our webinar.
Thank you, Artur. Thank you, everyone. Thank you for coming. Good morning, good afternoon. The subject of this webinar are Chiari malformations, and I apologize for the delay in starting my connection due to some unavoidable problems. And now I would like to call the first presentation, Dr. Zulma Tovar Spinoza from the sunny upstate Medical University of USA. They will talk about Chiari I malformation, pathophysiology, and diagnosis. Dr. Zulma, please.
Thank you, Professor Salomão. Sharing my screen. Can you see my slides?
Yes.
All right. So, hello, everybody. I'm really honored to present this topic about Chiari I malformation. And what is this important is because, you know, Chiari is a big sack of diagnosis. It's a group of abnormalities that involve the rhomboencephalus and craniospinal junction contents. But currently, there is really no consensus regarding the precise definition, classification, etiology, and surgical management of this condition. They're usually classically described 4 types, and there are no anatomical or embryological correlations between them. And why is this clinically important? Because just to give you a prelude, a Chiari I malformation, which is the most common one, it's defined as a structural defect in the base of the skull and the cerebellum, leading to herniation of the cerebellar tonsils. It usually has a prevalence of 1 in 1,000, mostly asymptomatic patients and female. And the significance of this is that at some point, for some reasons that we really don't understand, it will affect the cerebrospinal fluid flow and it would create symptoms. So if I present you these 2 patients that I just saw in my clinic last week, and you look at these MRIs, and usually we look at the mid-sagittal section of an MRI, you see that this patient has these tonsillar herniations. It means the lower part of the cerebellum goes into the neck. And, there you can probably see the flow of CSF, and there is no really a dramatic picture when you compare to the other case, where I see a posterior fossa that is small, a hindbrain that is elongated with the foreventricle almost in the canal. You see a little bit of retrovascular, and then you will think, what is the difference in between these two patients? So the difference is actually even the other patient, the second patient, has a little bit of syrinx and there is no tether cord. The significance of this is for you to understand that this topic is so interesting that the first patient that you saw with minimal changes actually was very symptomatic. And the second patient actually had an MRI just because he got a head trauma and the Chiari was seen. And he is totally and completely asymptomatic. So what we do with this patient, so Chiari is the exception. For every 1,000 people, 20 or 30 have tonsillar herniations more than 5 millimeters, and only one patient will have symptomatic Chiari, which means that 1 or 2% of the adult population and up to 3% of children have tonsillar herniation that is greater than 5 centimeters, but only 0.1% become symptomatic. Isn't that interesting? When was this first described? First of all, 883, John Gleland was a professor of anatomy in Glasgow and was the first one to describe a hindbrain hernia in a child with myelodysplasia. But it wasn't later until 1891 that Professor Hans Chiari, who was actually a professor of pathology in Prague, described the first patient that he saw was a 17 years old that he did an autopsy with a typhoid fever. And he saw the tonsillar herniation, and then he collected more cases. The Chiari classification was created. And then in 1894, Dr. Arnold, which was in Heidelberg in Germany, described another case, and two students later, Orr, Schwalb, and Gerdet, include the Arnold name to the Chiari, and now that is why it's called Arnold-Chiari malformation. So classically, we describe 4 types of Chiari malformation. The Chiari 1, as I just presented, is the tonsillar herniation below the foramen magnum, more or equal 5 millimeters, usually no associated brainstem herniation or supratentorial abnormalities, and hydrocephalus is uncommon. The Chiari 2 will be very explained later on, which has many anatomical differences. The Chiari 3 is the classical occipital encephalocele that, as you can see here, and the Chiari 4 is a hypoplasia or aplasia of the cerebellum with no hindbrain herniation. But wait, there is more. Now, there are also transitional forms of Chiari. There is the Chiari Type 1.5, which is the tonsillar herniations in the Chiari 1 with the addition of an elongated brainstem, and you see that the foreventricle actually is low. Or the Chiari 0, there is actually no tonsillar herniation, and there is a syringomyelia, which I believe is a tether of the arachnoid that cause a problem with the CSF flow. So if we recap, the Chiari type malformation 1 is the most common structural brain disorder involving the craniocervical junction. Yes, the caudal displacement of the cerebellar tonsils below the foramen magnum into the spinal canal, more or equal 5 millimeters. What is important again, it causes obstruction of the CSF pathways at the foramen magnum, and that alters the brainstem and spinal cord function. This form of Chiari is associated with syringomyelia or hydromyelia. Is more common in adolescents and actually adults, females on the 30s. And despite of that, the different types of Chiari 1, we really don't fully understand the pathway etiology, and we try to put all the treatments like in one size fits all surgical approach, as you will see later, but the results actually vary. There are several anatomical abnormalities related to Chiari 1, and in the skull, you see we have a list of them, most of them related to underdevelopment of the supraocciput or shortening of the supraocciput, shorter clivus, smaller shallow posterior fossa, empty sella, platyvacia, which is the horizontal clivus, basilar impression, which is not uncommon, midline occipital keel, or accessory occipital condyle. In the spine is related also to Klippel-Feil deformity, atlantoaxial assimilation, retroflexion of the odontoid, thickening of the ligamentum flavum, that's described in surgeries, and sometimes you cannot see that on the MRI, and scoliosis. In the meninges, there is an elevated slope of the tentorium, thickening of the arachnoids, foramen magnum, which is what I am a truly believer that if you don't open these arachnoids and do the untethering of the arachnoid leases, of the arachnoids, there you are not really curing the Chiari, but we will debate that after. Constricting dural bands at the level of the foramen magnum and posterior arch of the atlas, and veils of the arachnoid that obstruct the foreventricle, which why I called Chiari just an upper tether cord syndrome. Most of the 50 or 75% of the patients will present syrinx, and obviously we can also have the medullary kinking, the elongated midbrain, and the tonsils pet-like appearance. But how this happens, we really don't know. There are so many, and this is the resume was an updated paper that was just published, the different ways that we try to look at the genetics of Chiari. So in the early 90s, we believe it started to look at, okay, there are siblings that actually have Chiari, and why that happens. 12% of over the 300 patients of Chiari 1 malformation have one relative that have Chiari. Genetic conditions that are related to Chiaris are Ehlers-Danlos syndrome, achondroplasia, Klippel-Feil sequence, and other syndromes that you can read here. And any condition that will affect cartilage and bone, also syringohydromelia, hydrocephalus, skull and cervical spine malformations. Genetic findings are, we keep looking at the genomes and we keep looking at mutations. There are genomes that are specifics for patients that have, they are linked in family with connective tissue disorders, but we are further discovering there are mutations that are related to families that don't have these syndromes. And there are multiple genes that have been discovered lately about the structural aspect of the posterior fossa. We keep advancing on signaling pathways, identifying signaling pathways to identify communities between the Chiari patients. So Chiari 1 malformation has a complex genetic etiology with different genes contributing different families. And these genes are more active during development and before the symptoms even appear. And so we still believe that there is a multifactorial factor, a reason for the Chiari to appear. So there is a risk of inheritance, but we don't really have a formal or really reliable data. There is an incidental familial syringomyelia in 2% of the patients. The incidental familial Chiari is 12%. The inheritance can be autosomal dominant with reduced penetrance or autosomal recessive, as this paper was published. But the pathophysiology, again, and this paper which is out of the oven, we just published at the end of last year, shows you in one picture that there are multimodal evidence implicates genetic variants on the pathogenesis of Chiari. The multiple familial cases, the Mendelian syndromes, the whole exome sequences, the transcription regulation, craniovertebral osteogenesis, and embryonic developmental signalings. All of them are related to Chiari 1 malformation. How we put all of them together is still in a study, and the latest is the whole exome sequence of LAR patients cohorts that has begun to identify new candidate genes. So we are not done with that. The future research on genetic is to look patients that focus on symptomatic patients rather than asymptomatic patients, although we don't know the natural history. No studies have compared genetic findings between asymptomatic and symptomatic patients. The gender differences, why is Chiari 1 more slightly female predominance? When in pediatrics, what in adults is 4:1 to male predominance, and there should be a unique non-skull-based etiology in some female patients. The relationship between Chiari 1 and chronic pain, because we are discovering that some of these patients, there's a relationship between Chiari 1 and genes that have to do with chronic pain disorders. And more the cognitive deficits and the relationship with the Chiari-1 has been studied, and that like CHD7 genomics is associated with cerebellar malformations in Chiari-1 and potentially predisposing to cognitive deficits, yet we are still in the diapers on trying to figure out how that contributes to the Chiari. Obviously, when we think on Chiari, when we look at these images at this point, this is what you need to look at. If you have a tonsillar herniation, either you have something that is, you need to rule out that something is pushing from the top, something is pulling from below, or something is constricted, or you don't have enough space on your posterior fossa. It's just common sense. So it's either isolated or syndromic, or it is acquired. There are many etiologies, and I try to resume some of them for you guys. But obviously, I put in this table the most important ones. The congenital theory that was originally described by Arnold Chiari is that this is a congenital anomaly leading to underdevelopment of the posterior fossa and enough space and not enough space for the cerebellum. But there is the hydrodynamic theory that attributes the formation of altered CSF dynamics and pressure gradients pushing the tonsils down. There is the cranial settling that proposes alterations in the connective tissue or bone density that leads to the cranial base settling, reducing the posterior fossa volume. There is obviously the mechanical traction that there's one that needs to be ruled out, and that's why we do MRIs in these patients of the lumbar spine, that to rule out that there is a tether cord that is pulling the tonsils down. Primary mesodermal insufficiency described by Nishikawa suggests that the deficiency in the mesodermal tissue leads to underdevelopment of skull and spinal structures, or secondary volume is propose an increase in the brain volume that pushes the cerebral tonsils down. Tonsillar descent due to intracranial hypertension, and that's why we need to rule out all those pseudotumor cerebri in some of these patients. Parasagittal meningeal bands with parasagittal meningeals that can alter the CSF flow dynamics. Obviously, genetic factors, as we talk, or secondary volume loss of spinal cord or brain volume that leads to descent of the tonsils. There obviously acquired Chiari malformation, and what it put this sagging and MRI, sorry, this is an error, sagging MRI with contrast is because some of the clinicians usually don't order MRI with contrast when we study these patients, but there are forms of acquired Chiari malformation that has been described in patients years after they have an LP, a lumbar puncture, or the years after they have CSF leaks. And we cannot see probably those if we don't see the leptomeningeal enhancement in the MRI with contrast. But I put this list here just for you to look that we don't only look at the tonsils, but we can look at the effacement of the suprasellar cistern, the decrease of the pontomammillary distance, and the flattening of the ventral pons as another characteristics that can help you to rule out that the patient doesn't have a hypotensive syndrome. But what is the natural history of Chiari? I mean, why we have all these patients that we diagnose Chiari, the more that we do MRIs for other reasons that we find these patients, why do the majority of these patients don't develop symptoms or develop symptoms? So there is really no answer for that. Professor Di Rocco published this paper some years ago, and the impact of MRI images, the diagnostic, the discovery used to MRIs for various complaints. The diagnosis now we identify more in younger children. Most of the neurosurgeons will believe that asymptomatic patients rarely develop symptoms, and 83% of neurosurgeons actually will not operate on asymptomatic patients unless symptoms develop, and I'm one of them, because do you do surgery on the MRIs or do you do surgeries on the patients that have symptoms? So this is a question for discussion. Only 8% recommend prophylactic surgery without an associated syrinx. What is the dynamic nature? Some believe that Chiari malformation is dynamic, with the number of symptomatic patients increasing with age. But is that true? The challenge is deciding when and which procedure to perform due to the lack of reliable natural history data. So if we look at the studies that have been out there, similar MRI imaging characteristics between asymptomatic and symptomatic patients happens with the two cases that I presented at the beginning. No asymptomatic patients develop symptoms over 1 or 12 months of clinical surveillance by genitory. Nishizawa said low-term outcomes in asymptomatic adults showed a benign course with conservative management justified anti-neurological changes are detected. And about 50% of the patients with syringomelia show decreased serum size with improved symptoms after decompression. Is there any spontaneous resolution? It's rare in adults. We see those in children, and possible explanations include that there is a difference between growth rates and change in the venuses and sinuses. And how we manage these patients then, and what is the neuropsychological assessment that we use for them. We actually do a neurosurgical assessment on all of them, and that is important to study as well. Can Chiari regress? Yes, it was published that in 221 patients in the first decade, the tonsils, actually the description of tonsillar ectopia varies, and more than 6 millimeters in 6 decades, 5 millimeters in the second, third decade, more than 4 millimeters in the fourth decade, and 3 millimeters on the fifth decade. Can improve by its own? Yes, as I described yesterday, they can be changes on the posterior fossa growth or spontaneous recanalization of CSF pathways in the foramen magnum, or had been described that brain atrophy can solve the Chiari or rupture of the syringomyelic cavity into the spinal subarachnoid space. What are the classical symptoms of Chiari? So the symptoms are either because of decompression of the cerebellum, the brainstem, the cranial nerves, disruption of the flow, the CSF, and damage to the nerves. Probably the most important paper that has come out there is the Conquer Chiari Patient Registry, with 768 patients that actually describe their own symptoms. And why this is challenging is because if we look at the list of symptoms presented there, more of the symptoms at the eyes of a neurosurgeon have nothing to do with the Chiari, but is that really truth? We talk about symptoms of ENT symptoms, gastrointestinal symptoms, troubles sleeping, etc., but also the universality of the cognitive complaints. But the common symptoms will be that, first of all, many people with Chiari malformations have absolutely no symptoms. But any combination of them may occur, especially headaches, visual problems, dizziness, audio problems, difficulty sleeping, hand numbness, balance issues, fatigue, and neck and shoulder pain. So if we see 3 patients, they can present in different ways. So probably the most pathognomonic description of the Chiari is the presentation of the headache, and it's a headache that is a posterior neck headache and that is severe. It can be short but sharp and very severe, and it's aggravated when the patient does a positive pressure Valsalva. So it's coughing, sneezing, or straining, or in children when they are doing bouncing activities and sports. But don't forget that 2/3 of the patients with Chiari have also migraine, which is a throbbing pain on usually one side of the head that can create vomiting, photosensitivity, and phonosensitivity. The patients can complain also about dizziness, balance issues, double blurry vision, hypersensitivity to lights, and sleep apnea that is described on 73% of the adults and 60% of the children. If the patient develops syrinx, there can be obviously loss of pain and temperature sensation in the upper torso and arms, loss of muscle strength.
Zulma?
Yeah.
Zulma. Sorry, Zulma. Our time is very, very restricted, yes? Could you summarize? Okay, thank you.
Yes, I'm almost done. And the psychological issues. In children, the symptoms can be subtle and non-specific, and they more can present as throat pain, also scoliosis, head banging, and developmental delay. Obviously, the presentation as hydrocephalus, and most of these patients are going to present as a foreventricular outlet obstructions, and therefore they will present as hydrocephalus, and the treatments could be ETV, VPG, and Chiari decompression. As I said before, they can present with symptoms of syringomyelia, and 20% of these patients will present with syringomyelia, and it's probably because of the construction of the cord, and the cape effect symptoms of the syringomyelia. All right, no, don't forget to rule out the tumor and Chiari, which is an isolated ICP syndrome that presents in 8% of the patients with Chiari. These patients will present with papilledema. And don't forget to rule out Ehlers-Danlos syndrome, which is the joint hypermobility associated with Chiari. And so it's connective tissue disorders that we call cervical instability. And the diagnosis, obviously, the most important part is the clinical exam, that we need to evaluate the cerebellar functions and the lower cranial nerve. The expertise of the clinical exam is important. Rule out the dysmetria, the adocalcinesis, and the balance on these patients, and look at the lower cranial nerves. MRI is usually it's gold standard test, but don't forget as a clinician that when the patient lies in the MRI, the way that the patient lies on the MRI can change the way that you measure those tonsils. And if you take this, usually the classical is the mid-sagittal view, but as some of us also evaluate the coronal views. And CSF flow studies and measure the tonsillar position, as I previously mentioned. A CAT scan can be helpful in places where we don't have access to the MRI, and you can make reconstructions. And you can add other studies, as formally said here, sleep studies, swallowing brainstem, myelograms if you don't have access to images, or evoke potentials that can help you before for diagnosis, but also for positioning. And the treatment approaches, we are going to talk about it later.
We'll do the treatment approaches. We have to wind this down so that the other speakers have time. This has been an incredibly comprehensive and very careful summary to date, but I really do need to exercise role here. Prerogative is, some degree of gatekeeper and timekeeper that we've got to move on to the other speakers now. So can you wrap up here, and what's your punchline in 30 seconds so that I can turn it back over to Artur and Professor Salomão?
I want you to just look at the key points that are here. Chiari is a chronic condition. Most of the patients are asymptomatic. We don't have consensus on definition, but we agree that it's 5 millimeters for Chiari 1. Multiple symptoms. The classical one is the posterior head and neck pain that aggravates with Valsalva maneuvers. Kids can be tricky to diagnose. Please don't forget to rule out hydrocephalus and tetracord. And more and more we keep and rule out other conditions that can usually we don't think about, as hypermobility, post-orthostatic tachycardia syndrome, or idiopathic intracardial hypertension. And other patients that carry just the expertise and the detail to questioning and evaluating them is very important.
And I think the listeners get a sense of the complexity of this just from what you've said. So thank you very much. For a nice summary. And Professor Salomão will take it over now.
Thank you, Zulma. If you have some questions or comments, please drop them at the question and answer appropriate box, that they will be responded at the proper time. To the next speaker, I kindly ask them to do not exceed the maximum time of 20 minutes. And then we'll go to the second presentation, Chiari Type II, pathophysiology and diagnosis, Dr. Mirna Sobana. Please, Mirna. Thank you.
Thank you. Thank you very much, Professor Salomão. Good morning, good evening, and also good afternoon for all participants from all around the world. Thank you very much, Professor Zulma, for a very brief and detailed presentation. So I just only continue with my topic, the Chiari Type II malformation, the pathophysiology and diagnosis. I have nothing to disclose. The Chiari II malformation is associated with myelomeningocele or other form of open spina bifida consisting of the herniation of the cerebellar formis and tonsils. Medulla oblongata, fourth ventricle, usually in the inferior portion below the foramen magnum. It's actually mentioned the first time by Cleland and also Hans Chiari, professor pathology of at German University in Prague. And Professor Cleland J. said that infant with myelomeningocele and hindbrain abnormalities similar to Chiari Type II malformation. And Julius Arnold published again myelomeningocele with herniation of cerebellum into the cervical canal. So the Chiari malformation type 2 preferred over the term Arnold Chiari malformation. The pathophysiology, I took it from the textbook of Pediatric Neurosurgery and some journals. There's so many theory about the pathophysiology of the Chiari malformation type 2. In 1083, primary, there's a theory about the primary dysgenesis of the hindbrain by Professor Cleland. It said that it helps to, the theory helps to explain that the CNS malformation in the posterior fossa, but it fails to account that for the cranial and supratentorial anomalies frequently associated with Chiari malformation type 2 and myelomeningocele. And the Professor Chiari, 1891, said that hindbrain prolapse as the consequence of the pressure from the above exerted by hydrocephalus. But again, the theory cannot explain that the hydrocephalus may start after myelomeningocele repaired. Rostral herniation of the superior cerebellum cannot be justified by the hydrocephalus. And then Professor Penfield and Coburn and 1938 explained about the caudal traction theory, that as the caudal traction exerted from below by the spinal cord anchored to the dystrophic spinal defect. But again, there's a case which is the young woman with the open spinal bifida didn't produce hindbrain herniation in similar condition with tetracord. So many of the CNS deformation, this theory is further flawed by the fact that traction force applied at the lumbar spinal cord are essentially not existent beyond 4 spinal level from the tethered side. And then there's again the unified theory by Professor McClone and Neidig in 1992. Professor McClone and Knepper said that the both open neural tube defect and incomplete spinal occlusion allow CSF to drain through the central canal, and it is therefore not maintained in the ventricular system. Ventricular distension is required to induce the both neural and calvarial development, and without this ventricular CSF driving force, the posterior fossa never fully develops. With later rapid growth of the rhombencephalon of the cerebellum is forced, both cephalad and caudate along the brainstem, and the polymicogiri enlarge of the massa intermedia, low-lying tentorium, and torcular herophily. Base of skull anomalies are produced by the stem lack of the ventricle distension in the telencephalon. So explain the development of the hydrocephalus due to impaction of the posterior fossa contain the foramen magnum with the CSF outflow blocked or impaired at the foramina lusca and Magendie progressive ventriculomegaly might result. This doesn't explain those cases hydrocephalus and cerebromegaly in the fetal life, unless considering them as the effect of the hindbrain malformation. And it continued by Professor William 2008, the unifying hypothesis of the hydrocephalus, Chiari malformation, syringomyely, anencephaly, and spina bifida. The first theory that the posterior cerebellar fossa hypoplasia associated to Chiari malformation type 2 prevents the exit from the spine to the head as the blood enters the central nervous system during the movement, causing the syringomyely and the spinal cord damage found in the open spina bifida. In turn, there's two conditions prevent the escape of the CSF from the head to the spine, favoring the occurrence of the hydrocephalus and the brain found in anencephaly. There's a multifactorial theory, Massimi et al. 2011, presence of the other brain and membranous bone offering malformation remain partially explained, though suggestive more complex anomaly involving both neuroectoderm and mesoderm. And how we can diagnose the Chiari malformation? The early diagnosis intrauterine could be by ultrasound. For the head, we can find the Lemon sign. Lemon sign is a bifrontal indentation or frontal scalping. Can be, but it can be associated with Dandy-Walker malformation, so it could be the differential diagnosis. And the banana sign we can found as a closure of cisterna magna and a consequent displacement of the small cerebellum occurred toward the posterior fossa. And we found also from the ultrasound intrauterine, we can find the myelomeningocele. The postnatal diagnosis from MRI craniospinal, T1 and T2 sagittal, we can find a small posterior fossa, caudal dislocation of brainstem, fourth ventricle and cerebellum, large foramen magnum and spinal cervical spinal canal, short and scalloped clivus, hypoplastic and down-attached tentorium, the elongation of the vein of Galen that joins the shortened straight sinus, low transverse sinus is lying close to the enlarged foramen magnum. This is the picture of it, and this is as the Professor Zulma already mentioned, the difference between the normal brain and the brain with the Chiari. We have the tonsillar herniation through the foramen magnum here. And this is the difference between the normal and Chiari malformation type 1 and also the Chiari malformation type 2. In the Chiari malformation type 1, there's only a small frequency of the hydrocephalus happen, but in the Chiari type 2 malformation, always associated with open spina bifida, and 80 until 90% associated with hydrocephalus. And we can see the tactile plate deformation is weakening, and there's a downward displacement of the cerebellum, brainstem, and the fourth ventricle downward. And this is the differences between the Chiari type 1, Chiari type 2, and Chiari type 3. We highlighted the Chiari type 2, which is the posterior cerebellar fossa, is smaller, short, and concave clivus, and large foramen magnum, no basilar impression or invagination, low attachment of the tentorium or hypoplastic. What happened to the hindbrain herniation? The cerebellum in the Chiari malformation type 2, cerebellum still exists. The brainstem also cerebellar is herniated brainstem, and also can be followed by fourth ventricle up to C3 until C5 or often more. And associated character anomalies in Chiari type 2, there's there's usually or almost all with myelomeningocele, and then 80 to 90% with hydrocephalus, and 5%, the less of that, about 5% with serinomelia, wrapping of the brainstem by cerebellum, brainstem, midbrain, interhemispheric, and cortical malformation. Here we can see a picture with typical Chiari malformation type 2 with herniation of the cerebellum, the tonsil up to the C3 here, and dislocation of the lower part of the fourth ventricle, and medulla below the enlarged foramen magnum, low attachment of the tentorium and beaking of the midbrain, and large massa intermedia, hypoplasia of the corpus callosum, and stenogyria. And the B and C is, it shows the wrapping of the pons and the medulla by the cerebellum. From the CT scan, we can make it with the 3D reconstruction. We can find the typical dysplastic lacuna, copper beaten, which present at birth in about 85% of cases, in disappear later. Not as that is not a sign of the rise ICP, but it's an expression of the intrinsic mesenchymal defect. Can find also enlarged foramen magnum and upper cervical canal, short and scallop clivus. The absence of the basilar impression or invagination, scalloping of the petrous pyramids, shortening of the auditory canals, flatten of and convex upwards occipital squama, incomplete neural arc of C1 in 70 cases with intact C2. Inion is low, as well as the attachment of the tentorium and the marking of the venous synosis. From the plain X-rays, we might need it to rule out the instability of the craniocervical junction and to monitor the progression of the scoliosis or other orthopedic spinal and non-spinal deformities. Ultrasound, we talk about the ultrasound intrauterine, but now we talk about the ultrasound postnatal. For neonates and infant with open bony, which is still have the open bony acoustic windows, we can monitor the ventriculomegaly, and we can detect the incipient hydrocephalus. The Chiari malformation type 2 can be visualized through this posterior or temporal fontanelle, and we might use the ultrasounds to detect agenesis or dysgenesis of corpus callosum and or septum pellucidum. And other diagnostic tools, we might use the polysomnography to detect the sleep apnea that usually happen to the patient with the Chiari malformation type 2, and also brainstem auditory evoked potential or BAEPs to find out the brainstem dysfunction. Special consideration on two frequent associated disease is the hydrocephalus, which is 80 to 90% of the patient with open spina bifida, and syringomyelia most common in C1, and C2 accounts only about 5%. It's from Williams 1919. And hydrocephalus can be detected the earlier from the ultrasound and for clearly from MRI or CT scan that shows a large ventriculomegaly with raised ICP signs. There's a bulging profile on the ventricle, CSF transependymal reabsorption. Only on the 5th or 1/4 case, 1/5 or 1/4 of the case, while often is about progressing but moderate ventriculomegaly. Can see here the 2 months old with the severe hindbrain herniation up to C6 as a result of very small posterior fossa of cerebellar. Is attached to the foramen magnum. and a large hydrocephalus. The fourth ventricle is hardly recognizable. Dorsal syringomegaly is evidence. We can have the differential diagnose the Chiari malformation type 2 with the Chiari malformation 1, which has no myelomeningocele cell and may have brain descent, and isolated meningomyelin cell with no posterior fossa abnormality. Also, but it's very rare with the spinal astrocytoma, chordoma, or encephalous cell. The conclusion that there are dynamic research about Chiari malformations type 2, hydrocephalus, and spina bifida, and the theory of pathophysiology might be changes or have a new additional hypothesis in theory in the future, and the diagnosis technology may still improve as well as the studies still going on. Thank you very much. I will stop sharing screen.
Thank you. Thank you, Mirna, for your very, very good presentation and for keeping the time established. Now we'll move to the third presentation. That's Chiari decompression indications and techniques. Dr. Deepak Gupta from India. Just remembering you that if you have any question, you can go to the question and answer topic. Please.
Thank you so much. Thank you so much for the ISPN for this opportunity. In the next few minutes, I'll be sharing my views on indications and techniques of Chiari decompression. I think the most important thing for treating Chiari malformation is to understand the various mechanisms which are responsible, especially the mechanical compression and the hydrodynamic factors which lead to the actual Chiari. So all the evaluation investigations have to be centered for those pathophysiological processes to be able to reach to a diagnostic decision. Now, I think we must understand that it's an incidental finding in over 60% of the cases, and majority of these cases can be very well managed conservatively. And I think the management of Chiari, in my understanding, is like like answering a question whether the chicken came first or the egg came first. There's so many issues. It's been over a century since we know about Chiari, but whether the hydrocephalus leads to Chiari or the vice versa. And so for the tethered cord syndrome or the scoliosis relationship to the Chiari, again, remains quite controversial. The various theories for Chiari, as my previous two speakers have talked about, whether it's a compression theory or a traction theory, again, remains quite debated as of today. And I think even in the management, there are two groups of people, I would say. There are some people who are like decompressors, which I'll be talking about, who strongly believe in the concept of foramen magnum decompression and various other ancillary procedures. And second group of people are the people who are called as the fixers, those who believe in kind of fixing the craniovertebral junction. I'll touch upon each of these slowly. I think the first important thing is who, when, and how to operate. I think we understand as of now, most of the patients who are asymptomatic, which is almost 90% of the cases, they can be observed. Patients who are having atypical headache or minimal symptoms, and especially more so in the children, they can be very well observed. In fact, most of the British people, to my understanding, they have taken more of a conservative approach to the management of Chiari, which is quite rightly so, I believe. The patients who have got symptoms with pointed tonsils, descended tonsils, with medullary kink, I think 100% of these cases do merit surgery. Of course, they should be having a very classical symptomatology, which is a cough-induced headache, a severe headache. There should be a kind of a symptom should be matching with the disease pathology. And even the asymptomatic cases with significant syringomyelia, 80% of these cases merit surgery. If I'm to answer when should we operate these patients, I think I don't have an answer to it because there is no literature available as of now. But the dictum that says is that early surgery prevents neurological deficits. So you should operate these patients as early as possible. So if you have a patient who comes to you with incidental diagnosis of Chiari malformation, you must do a proper neurological evaluation and of course screen the entire spine with MRI, the whole spine, and CNA flow studies to see for any CSF blockage. And in case you find everything normal, then you can very well manage this patient conservatively with neurological follow and annual screening MRIs. However, in case you pick up evidence of small or medium or large size serings, and if there is some clinical or radiological deterioration, then these patients do merit neurosurgical consultation for possible decompressive surgery. Now, how should you operate these patients? The basic thing which remains to all the procedures is the bony decompression. That is called foramen magnum decompression. There's a lot of debate and controversy, and different surgeons approach the pathology differently. Mostly so in children, wherein most of the surgeons, they prefer doing a bony only foramen magnum decompression, especially more so when there is no serings. However, a certain group of surgeons, they prefer doing a kind of limited dural scoring or the durotomies, wherein the outer layer of the dura is kind of incised with a fine diamond knife, which preserves the arachnoid. And then you can also offer these children or adults foramen magnum decompression with duroplasty. And the most radical one procedure would be foramen magnum decompression with tonsillar coagulation and arachnoid debridement and some amount of obex opening and duroplasty. The fixation part, the transoral decompression for the ventral decompression of these patients, or occipitocervical fixation or C1, C2 fixation, is highly debated as on today. Management of these cases with procedures like syringostomy, syringe shunt removal, insertion internal, external, it is quite infrequent, and I think it's used only for the failed cases. In my personal opinion, I don't prefer these procedures in large majority of my patients. For the secondary Chiari, there will be some talk by Dr. Girish Solanki at the end, especially in patients with the craniosynostosis. So the secondary craniocephalic disproportion plays a relevant role in the genesis of acquired Chiari in children bearing extrathecal. Let's say, for example, you put some lumboperitoneal shunts. These patients may develop secondary Chiari, and you have to manage these patients accordingly. Why different operations? It's something like an Occam's razor. I think the problem or the discussion, there's so much of debate which is happening in the international world on different management options is primarily because different people understand the pathology or pathogenesis of Chiari differently. Some believe in piston theory, some believe in water hammer hydrodynamic theory, and some talk about the CSF flow obstructions. The Italian group of people, and even I think Shlomi Constantini is a very firm proponent of doing for standalone foramen magnum decompression with dural scoring, and especially more so in the children with very good results they have got. These are the few publications which have come up with the University of Messina, Professor Tomasalo and Professor Di Rocco, my mentor, and they have presented a reasonably good number of series about foramen magnum decompression with dural scoring with good outcomes. However, children with rapidly developing deficits or with a Pope's angle of more than 35 degrees or tonsils reaching up to the level of C2, these are the ones who do not benefit significantly with dural scoring alone. The paradigm of Chiari 1 malformation is evolving. I mean, if you talk about this group of surgeons who take a conservative approach, like the Italian group of people or the British group of people, and the people who take an extended approach. There was a very nice publication which came up in neurosurgery, wherein they compared the foramen magnum decompression with foramen magnum decompression and duroplasty. And very interestingly, the clinical improvement was noted to be almost similar, 62% improvement in the bony only, and 63% in those who had a duroplasty. But if you look at the length of the stay was definitely longer in patients where the duroplasty was done, the reoperation rate was slightly less, but the complications were definitely higher in patients who had a duroplasty. The reason why people prefer duroplasty is owing from the fact that a certain number of these patients, they have got some amount of fourpendicular outlet obstruction, with some people reporting like arachnoid veils and some amount of fibrosis around these tonsils. The veils are these midline structures, while the scarring or around the tonsils is quite just at the fibrotic tonsils. So the people, when they open the durotomy, they like to open these structures, and then of course there's a very good CSF flow established subsequent to this. Now, Chiari 1 with the syrinx. There is a nice paper which was published by Benjamin C. Kennedy in 2015, wherein they noted that in those patients where the dura was not open, when there was no dural opening, the syrinx did resolve. However, it resolved over a slightly longer period of time. These are the patients where the duroplasty was done, and these are the group of patients where the duroplasty was not done. So there was a 70% improvement in the syrinx, even in the patients when the dura was not open. It was slightly at a longer duration. However, the clinical improvement was noted in 100% of the cases, and the radiological improvement was noted in 26% of the cases in the initial part. Now, those group who believe in extended decompression, by this I mean bony decompression with duroplasty with arachnoid opening. Of course, you have got lower recurrence rates, you have got favorable long-term prognosis, and there is some amount of mortality in some series. However, it's no longer reported any longer with experienced hands. And CSF leak and pseudomeningocele incidence is slightly higher to the tune of 6 to 8% in these cases when the dura is open. And this was the large series of 371 patients, 25-year follow. It was an adult series. Interestingly, in this series, if you note, syrinx was noted in 86% of the cases. Arachnoid was open in 347 out of 371 cases, and duroplasty was done in all cases. And what you see very striking is that autologous duroplasty, the pericranium or the gallia, was used only in 24% of the cases. And they also noted that the factors responsible for the recurrence was the experience of the surgeon was one of the factors which was responsible for neurological recurrences in this group of patients. So should dura be open? The majority of the people who believe in the concept of dura should be open, they believe that because there's an early collapse of the syrinx, so the syrinx resolves, and of course the symptomatology also improves. But I think symptom improvement is independent of the complete syrinx resolution. So this is something which has to be understood by the surgeons who are doing Chiari decompressions on a regular basis. So bony posterior decompression has got very low rate of complications, but it has got a higher risk of persistent symptoms, and it can be considered in the children without severe symptoms or the large syringomyelia. The key points of duroplasty are to keep unviolated the arachnoid plane and to perform a proper dura closure, which is the most important part in the management of these patients. As you can see in this diagram, the patients who had got the red ones, those who had got duroplasty, definitely they had got earlier syrinx resolution. And the patients who were younger, the younger patients, they respond in a much better and a faster way, I would say. Next controversy comes about the tonsillar resection, whether the tonsils should be resected or there should be some amount of subpal tonsillar coagulation or shrinkage. Why it should be done? Of course, because there's a chronic compression, and some usually reserve it only for the severe cases with the severe syringomyelia in their group of patients. And why it should not be done, especially more so in the children, because it has been seen that there have been 50% of the redo cases due to the arachnoids additions post tonsillar resections. These are few of the publications which are available in the literature, wherein they've talked about the kind of the technical note on how to do the tonsillar coagulations and what are the improvement rates in this group of patients. However, the larger evidence says that especially in the children, avoid tonsillar manipulations. In fact, this was a very interesting case, a 16-year-old girl who presented to me with two-year history of headache. And she had a headache which was reflected to the medical management. There was no hydrocephalus, no low-lying tether cord, and she had a Chiari 1. And in that patient, she made a good recovery, but incidentally, we picked up a cerebellar infarct in the inferior cerebellar hemisphere in the pica territory, probably from the vasospasm, because review of the operative video showed there was no evidence of any coagulation used. So, but it can happen to any patient. It can be have some neurological sequelae. However, we got away, and this patient, this is the MRI which we got it done 6 months later. The tonsils are very nicely reduced, good CSF flow, and the infarct has healed. The patient is doing well. However, I think tonsillar coagulation in the absence of syrinx is probably an overkill. If you compare the children with the adults to talk about the results or comparative results between duroplasty alone or duroplasty with tonsillar coagulation. I think it's safe to do tonsillar coagulation even in the children, but there's no difference in the series of the clinical outcomes as per this pilot study which has been published. And of course, we need a larger sample size to give a definitive answer to this. And these are the same results which are there in the adults also. If you ask me about what kind of graft is to be used, well, worldwide it is accepted that autologous graft is cost-effective, less incidence of pseudomeningocele and less CSF leak. However, this paper, which was published in Neurosurgery of 371 cases, autologous duroplasty had got higher rates of post-operative deteriorations compared to allografts. Now, to talk about Chiari with AAD and basal immunization, this is a very hot and debated topic, and primarily the credit goes to Professor Atul Goel from India, who is kind of a fixer, and he believes that tonsils are the airbags. Those who believe that it should be decompressed, they believe that tonsils are not an airbag. I think we need to have some amount of a balance. Because there's always a dilemma whether we should address the Chiari or the instability. You should stage the procedure, and what should be the amount of decompression. In my practice, I always have a high index of suspicion. I do dynamic imaging, and only if I'm able to document instability, then only fix up these cases, not otherwise. And this was a beautiful paper which was published by Dr. Sanjay Bihari from SGPGI, which tells you which are the patients of Chiari with C1, C2 instability you should fix and which are the patients you should not fix. Of course, patients who have got connective tissue disorders, CVG reduction, stabilization, and fusion should be considered only as a last resort after reasonable course of non-operative treatment. Some people have attempted polar therapy in Chiari malformation, but I think it's just buying some time. And in the end, majority of these patients with symptoms, they require some amount of surgery. Similarly, for patients with the Chiari with hydrocephalus, I think the rules are very simple. You must address the hydrocephalus first, and ETB is the treatment of choice to begin with. And some of these patients you can very well manage with ETB alone. There is a controversy regarding Chiari with tethered cord syndrome, but I think the current consensus is that tethered cord is kind of a more of an association and not a causation of Chiari malformation, and you should detether only the symptomatic ones, not the occult ones. To manage failures, these are the various options which are available in the literature: tonsillectomies, syringostomies, odontotectomies, and of course some amount of re-exploration needs to be done. These are the few guidelines which have been published, the consensus guidelines on the pediatric cases in 2022. You can just go through it, but the most important message is that surgical treatment is not decided on the MRA pattern in the asymptomatic children with tonsillar ectopia and with the 20 millimeter without syringomalia. And these are the CNS guidelines published on systematic review, which also talk about class 2, class 3 evidences about if there is no syringe improvement, one can offer resurgery in this group of patients. This was an interesting case in a child who had a CSF leak in my series, and when the child came to the ward and the resident was was closing the skin, he accidentally injected xalocaine, and many of you do not know this xalocaine contains a preservative called methylparaben, and it can cause anaphylactic reaction. In fact, this child developed anaphylactic reaction and had to be intubated for a day and was subsequently discharged home. So by this, I just want to say that there can be any amount of complication which can happen in your group of patients. Just last two slides, I'll show you how the technique. I usually place these children in the military tuck position. I do a 2.5 by 3 centimeter kind of a occipital connectomy. And in fact, I do more on the wider side in my patients. The lateral extent has to be more wide. Once I take out this flap with the help of a M1 Midas, subsequently I do durotomy and duroplasty in all my cases. I attempted dural scoring in some of my cases, but I was always worried about this the CSF leaks. So in my series, I always do this. Regarding tonsillar coagulation, I do it only primarily in the adults and those with the large tonsils going up to the level of C2. Once the dura is opened, or the bands, if there are any, they can be addressed and they need to be taken care of. In some patients, I have addressed by doing tonsillar coagulation. This particular video on the right, you see a child with a groin skull fracture actually, and the ICP dropped from 9 to 2 the moment the durotomy was done. And of late, I have started using Duragen, collagen, and with some glue. And I have not had any CSF leak in my last few cases of Chiari malformations. So to summarize, I would say that foramen magnum decompression with duroplasty has got low reoperation rates and more clinical improvement. They kind of outweigh the CSF complications. My understanding is that in a country wherein the follow-up is an issue and where the patient has to struggle to get readmissions in case needed, I think one should do a complete procedure early, because we all know that standalone bony decompressions, there is some amount of recurrence rate and these children do come back. Regarding tonsillar shrinkage, I do it only in the adults. It's by personal preference, and I use a lot of collagen matrix or the bovine pericardium in some of my cases with reasonably good results. I don't do any C1, C2 or occipitocervical fixations in the absence of C1, C2 instability. I don't use any collars for Chiari 1. And of course, Dr. Girish will talk about PCA without FMT in syndromic rhinosinusosis, which in my hands also has got excellent results. I have a very low threshold to early surgery in the symptomatic Chiari. So the only message I want to give is that when you have one chance, where there's a long waiting list and loss to follow-up chances are there, give the best in the first shot and practice what gives you the best results in your hands. And you can see this spaniel. I don't know if many of you will be knowing this, the Great Cavalier Spaniel dogs in the King Charles kind of empire. They are the ones who have got Chiari. So it's not just the man, but the beast also who are born with the Chiari malformations. Thank you so much.
Great.
Professor Salomão, I think you're muted, sir.
Okay,
There you go. Much better. Thank you.
good. Are better? Are you hearing me?
Yes, very well.
Okay, thank you.
Yes.
Well, we'll pass now for the next presentation. That's a very provocative one. A symptomatic Chiari. Is there something like this? It will be presented by Kaushal from India. Thank you, Kaushal. Kaushik, go on.
Thank you. Can you see my slides?
Yes,
Okay.
yes, very nice.
Thank you,
Perfect.
ISPN, for this opportunity. And I will start where Deepak has left. That I work in a country where the follow-up is erratic. There are children, especially, who are lost to follow-up. And so this is more relevant to our context. What do you mean by an asymptomatic? An asymptomatic, by the dictionary, says that it is not causing or marked by or presenting with any signs or symptoms of infection, illness, or disease. But actually, what we see or label as asymptomatic is either post-symptomatic, or it is a radiologically symptomatic but clinically not, or it is an uncommonly symptomatic, or it is presenting in a delayed fashion, and very delayed in early adulthood, and there are missed symptoms either on the part of the doctor or from the radiologist, and all of these can be falsely labeled as asymptomatic. So the idea of my presentation is to just highlight to the students or the residents or the young doctors what are the caveats of labeling Chiari as an asymptomatic. As already been described, it is a dynamic disease in which the etiology and the radiology and the clinical parts may not completely tally in all cases. Now, if you see the long-term outcome of incidental Chiari in the literature, we'll find that Chiari is an incidental finding in 0.8 to 3.6% of the cases. And there are subsets of patients who will go on to develop de novo settings. There are subsets of patients who will present in a very delayed fashion in adulthood. And at a mean follow-up of 5 years, 20%, that is 1/5, will go on to require surgery. And by today, we have no formula to identify how to identify these subgroups. So, what are the common symptoms? We have already outlined. Common symptoms are headache, neck pain, ocular motility disorders, cerebellovestibular signs, and long tract signs. And especially the headache is exacerbated by Valsalva. Take this case. This is a 6-year-old girl presented with fever during an epidemic of fever that we occasionally have during especially the monsoon season. A scan was done to rule out encephalitis, and it revealed a big tonsillar herniation. So she was suggested for surgery, but initially was refused by parents, and she came after 4 months with sudden onset of respiratory distress and died in spite of an immediate posterior fossa decompression done by me. I could not save this child. The other patient is a 3-year-old girl presented with an episodic vague headache lasting for 2 to 3 days, and she was being treated as a childhood migraine. And on insistence of the parents, the neurologist did an MRI, and she was found to have a big Chiari malformation. Both of these cases were Chiari I malformations. The third case is a 9-year-old girl child presented with some symptoms of tiredness after writing for a long time. She was an exam going, school leaving exam, and she complained of a tiredness after writing for a long time. And she was brought before the exam by the worried parent. And on MRI, a Chiari malformation was found, and within few days, she went on to develop ocular palsy. So there are some under-recognized symptoms which may be falsely labeled as asymptomatic, like cranial neuropathies like papilledema, even trigeminal neuropathy, hemifacial spasm, high-frequency sensory deafness, atrophy of the tongue, poor weight gain, subtle cardiac symptoms like sinus bradycardia, postural tachycardia, arterial hypertension, sleep apneas of various forms like central sleep apneas, obstructive sleep apneas, mixed sleep apneas, and as Dr. Juma has told, there are a lot of patients with cognitive impairment, brain fogging, impairment in attention, visual-spatial skill and language skills, impairment in working memory, emotional content processing, language development, which all may be overlooked due to or attributed to other causes in children. And even in adults, some behavioral disorders like anxiety, depression, panic, obsessive behavior, dysphoria, especially some symptoms in neonates. I work in a high-volume neonatal center where the pediatrician comes in round before me, and they always show these symptoms and attribute these to other causes, like unexplained irritability, inconsolable crying, opisthotonus, breath holding, stridor, reflex. Even when they see a platybizy on X-ray, they say, no, there must be something else. We must investigate from head to toe. And other things like apneic spells, clumsiness, respiratory dysthymia, dysphagia, hoarseness, or even sudden death are seen in neonates who have a missed Chiari. It is not always possible to take a neonate to an MRI scan unless you have a sufficient strong point to do so. So these diagnoses are often missed in a neonatal unit. And you see, this is a paper which shows an outcome related to the age, and it shows that in neonates and infants fare worse during even after foramen magnum decompression. Children below the age of 6 years fare much worse than the children from 7 to 18 years. So there is an importance of a quick diagnosis, and there is an importance of, of ruling out labeling the symptoms. Please pardon me because there is something with the computer. Now coming to syrinx, as you all know, that Chiari 0 malformation, as I've outlined, is syrinx without a tonsillar herniation. Then is a syrinx itself a symptom. So if the tethered cord is ruled out, then the syrinx is most likely in that patient is due to congenital arachnoid bands, what Dr. Deepak has just alluded to. for which there is a need to do open durotomy and to take out this arachnoid bands. And in some patients, there has been seen there is a crowding of around the foramen magnum in additionally, even in Chiari 0 patients, what we call as tight cisterna magnum. So we can safely assume that Chiari 0 and Chiari 1 are part of the same spectrum. They need to be treated as such, and therefore, also you have to consider that in a very young patient, the deleterious effect of the settings on the anterior horn cells, and therefore, if the settings must be considered as a symptom and must be treated forthwith. Now, is headache a reliable symptom? Headache with Valsalva is a reliable symptom. But young children with Chiari may present with headache not exacerbated by Valsalva. And headache not exacerbated by Valsalva in children rarely warrants a craniocervical imaging. But you must take in consideration that intermittently herniating tonsils can produce headaches, which can easily mistake in young children. So headaches not relevant to standard neurological therapy must warrant a craniocervical screening. Then there are acute presentations that I've showed in my first case. They may present following trivial trauma, following enlargement of syrinx, following a respiratory tract infection, following a BP shunt, and even they can be followed just like this. And they may present in various forms, like either raised ICP symptoms, or fluffiness in the young adults, or spasticity in children. And this occurs due to an acute rise in the perimedullary pressure or the cord signal changes. And it carries around 20% mortality. So acute presentation usually comes with a loss of consciousness, respiratory difficulty, and acute neck pain. And it may be misdiagnosed as cerebellar fits, apneic spells, scura, Guillain-Barré syndrome, cryptic avian, pseudotumor cerebri. The literature is full of this misdiagnosis in acute presentation of Miss Chiari. So it is very, very important that these patients are potentially salvageable. We must just screen the child very minutely, both clinically and radiologically, before labeling a Chiari as an asymptomatic one. And FMD, in most cases of this acute presentation, a foramen magnum decompression, even in that crisis situation, is a treatment of choice and not a CSF diversion. Then coming to the radiology, MRI, which is done in a supine position, can overlook a skull-based bony abnormality, causing a function which may cause a functional Chiari when the child is standing up or during neck movements. Dynamic CT scan, therefore, can give a clue to this. And as Dr. Deepak has said, there is a role of dynamic CT scan in almost all cases before you brush away at anything as fully asymptomatic Chiari. Then there's a case of arrested hydrocephalus with tonsillar herniation. Yes, the hydroventriculomegaly is now arrested. The tonsillar herniation may be asymptomatic now. But what will happen when the child will grow, when the brain will grow? Will the herniation will further progress? So this needs a close follow-up. Next is the position and the shape of the tonsils. Normally, they say that tonsillar tip below 5 mm is Chiari 1. But if you have a concomitant craniocervical crowding, like a low posterior fossa volume or a bony abnormality, then the tonsillar tip, a descent of more than 3 mm is pathological. And this craniocervical crowding may be overlooked in MRI if not specifically searched for. So again, the importance of CT scan along with MRI. Then the shape and position of the tonsil. Normally, we have the classical teaching is that in Chiari malformation, the tonsillar herniation, the herniating tonsil is peg-like, but a round tonsil below the foramen magnum. Is this a symptoms? A tonsil below foramen magnum with a ventriculomegaly is again a chicken and egg situation, what Dr. Deepak has said, which is primary, which is secondary, you don't know. But I tell you, the obex position is a key. If you have even a Chiari with an obex below the foramen magnum, definitely, even without a settings, a surgery is warranted. The obex, as shown in this level D in this picture, is a position of the normal obex. The obex is placed below the foramen magnum in a mid-sagittal MRI, then it is a key indicator of surgery, even if it is asymptomatic, even if there is no syrinx. And then how accurately can you diagnose tonsillar herniation MRI? See, the sagittal image shows an herniation, the coronal image does not. Then again, you see the sagittal image, which sagittal image shows no herniation, but if you see the axial image, there is an herniation of the cerebellar tonsil in and around the lower medulla, where the addos are there. Again, tonsillar herniation in this picture is seen only in extension, which if you take a neutral MRI, it will be missed. So, and there are instances of a unilateral tonsillar herniation like this. See, one-sided tonsil is below and the other is not. So all of these are the caveats in radiology that you must search for specifically, you have to search for specifically. A DTI images have shown, even in asymptomatic Chiari, there are some degree of damage to the middle cerebral peduncles, bilateral pontine corticospinal tract, and the medial lemniscus. So what you are leveling as an asymptomatic clinically or an asymptomatic radiologically may not be actually such. And these occur due to prevention of CSF outflow back into the cranial side during diastole, causing a water hammer effect on the adjacent posterior fossa tracts. So before leveling as asymptomatic, all these caveats needs to be looked hardly at. So the take-home message is that before leveling asymptomatic, look at the age, especially neonates, look and again look. Look at the subtle signs of crowding around the foramen magnum. Look for the occult skull-based bony abnormalities. And in the investigation, do the investigation to reveal those. Look for brainstem deformation along with Chiari. Look for syrinx. Look for behavioral problems, unexplained behavioral problems in children or young adults. Look for sleep apnea syndrome, ask the parents or the caregivers. And look for occult tethered cord. So if syrinx is present and is asymptomatic, then definitely surgery is warranted. And for the rest, we need a close follow-up. Now, in close follow-up, by means, we usually, what we recommend is to follow up yearly, both clinically and radiologically. But for an asymptomatic Chiari, my advice will be not to do a yearly follow-up, but to follow up more closely, say 3 monthly or 6 monthly, and each time follow up both clinically and radiologically, because it is a growing skull. And also, the Chiari is a dynamic disease. So the dynamics are ever changing. So if you ask the patient to come back 1 year after, in between, he or she may present with an acute presentation. So thank you so much.
Thank you very much, Kaushik. We'll go now to the last presentation from Dr. Girish Solanki from the UK, who talk about ATV, cranial augmentation, and C1, C2 stabilization for complex Chiari cases. Girish, very good to have you here with us. Please go on.
Hello, Francisco. Can you hear me? Are you able to see the presentation?
Yes to both.
Excellent. Thank you. So good evening to everybody from Birmingham, UK. I'm privileged to be part of this August assembly of fantastic speakers. And I have to say, as being the last speaker, most of my slides are irrelevant because you guys have done such an amazing job. So my task today was to talk about long-term outcomes of endoscopic third ventriculostomy, craniocervical junction fixation, posterior coronary augmentation for Chiari and syringomyelia. So that's not the sort of thing that you hear every day. This is the old hospital where I work. I have no conflict of interest to disclose. And I just, lots of the stuff in here you've already heard, but I just wanted to highlight that if you think about a surgical Chiari, not just a Chiari syringomyelia, there are very important core components you must remember. So all of these cases will have a small posterior fossa, craniocephalic mismatch, increasing length of the cerebellar tonsils, which again, I would emphasize is not a tumor, but it's something that is causing the tonsils to get longer. Progressive reduction of the CSF space within the foramen magnum. So those are the things I wanted you to remember. And then things that we never ask. Why does a Chiari regress? What is behind the spontaneous regression? And when the Chiari progresses, what is causing the tonsils to grow? And how does a cerebellar tonsil grow in length? So can the right and the left cerebellar tonsils grow to different sizes? So these are the things that nobody asks, but you should think about it. Zulma made a very good description of the structural mechanisms, and I'm not going to repeat those. I have to say, I want to thank Deepak as well for a fantastic presentation. And what I want to tell you, to go straight into the algorithm of managing what Deepak very clearly said, secondary Chiari, but I call this complex Chiari rather than secondary. Now, the natural history of Chiari is now becoming very clear. And the interesting thing is that at 5 years, more than 85% of the patients may not need anything done because they just stay stable. 3 to 5% will regress spontaneously. So you still don't have to operate those as well. But 9.5 to 14% will progress. And that's what we are interested in. And what we want to find out is, do all the Chiaris progress equally? And the answer, of course, is no. Kaushik gave a very nice and very interesting presentation on the complexity of diagnosis. And I tend to just call a simple Chiari a Chiari that doesn't have secondary issues like ventriculomegaly, craniosynostosis, or loss of CSF craniocervical junction anomaly, syringomyelia, scoliosis. And those Chiaris, clearly, they don't need anything done. But the complex Chiaris often need a variety of interventions, different surgical procedures, and that's what I brought here. Most people say that if the Chiari is associated with a tonsillar descent of 12 millimeters, and there is development of syrinx, they would be driven to surgery. This is a very large survey from the ISPN. And the question really is, can you operate on all of these Chiaris by just doing a foramen magnum decompression? My answer to that is definitely not, and you must develop a careful algorithm to successfully treat this. We know that Chiari and syringomyelia have multiple associations, and you see those, and they're similar for both Chiari and syringomyelia. So how does Chiari and ventriculomegaly then associate? So you could say that, if there's a Chiari, it blocks the outflow of the foramen magendi and Luschka, and that then will cause obstructive ventriculomegaly. Or it could be the other way around, that the hydrocephalus will push the structures down and block them. So, you would get something we call supratentorial crowding, and that will then obliterate the cysternal CSF. So it's like the chicken and egg story, and technically probably both are associated in the development of Chiari. But for me, if you look at an MRI scan and you look at how the appearance of the posterior fossa is, so you can see here there's a small posterior fossa, the cerebellum is nearly standing up, is upright, the tent is very oblique, it's nearly vertical. There is a small, short, stubby clivus. The dolichoid dens is poking into the ventral brainstem. So all of those things are typical of what we call a supracerebellar crowding. Menezes, way back in 91, told us that 50% of the Chiaris are associated with skull base and craniocervical junction abnormalities. So this is why, when you think about it, a Chiari or syringomyelia can have multitude of causations, and I've listed those that in our institute have been identified with the Chiari and syrinx. We also did statistical analysis of a large series of our patients, and our statistician told us that the most likely patient to develop a syrinx is somebody who's 100 months of age, has a tonsillar hernia more than 12 millimeters, has a sagittal diameter ratio with a posterior fossa height of 0.6 or greater, and the clival angle and the foramen magnum clivus angle less than 0.8. So you can actually statistically work out who's going to develop a syrinx and predict it. So we started thinking, well, could this Chiari and syrinx be associated with small posterior fossa volume? And then why is there a progression? So we hypothesized that the progression must be because there is crowding from the supratentorial compartment, which is continually pushing the structures down through the foramen magnum. And if you think about a patient with craniosynostosis like this, it's not difficult to understand the rationale, because the intracranial pressure is going to push the tonsils like toothpaste being, squeezed on a tube. So that, I don't think there's any objections. But what if it is more subtle? And the subtlety is what makes the difference. You saw the scan that I showed you, but if I can show you graphically, what happens is, in a small posterior fossa, if you look at the normal situation, 1/3 of the cerebellum is actually above the line going from the posterior clinoid to the inion. But in where the posterior fossa is small, actually all of the cerebellum is actually pushed below, and that is why it starts herniating. And that amount of the occipital lobe that is lying below that posterior clinoid inion line is actually the one that is causing the supratentorial crowding, because it's actually lying where the posterior fossa was supposed to be. So this kind of sets the rationale for the treatment. So if you imagine that this yellow shaded area is the constricted part of the skull, then you could consider an operation where you could actually expand that area and return the size of the skull to a more normal shape. And by doing so, you would increase the skull volume and return the structures back to its normal position. The other thing that I wanted to tell you is, if you look at this, you can see that there's a Chiari, there's a syrinx, but you can also see that there is a dolichoid dens, there is platybasia, and basilar invagination. So how do you treat this? Do you do a foramen magnum decompression and then you go and fix, or is there a procedure that singly could deal with both? So this is why we then developed this algorithm. Now, I don't want to run out of time without telling you the long-term outcomes. So I'm going to tell you the long-term outcomes before I show you the data or the actual operation. So for the posterior calvarial augmentation patients, this was done last year when I was preparing for my presentation at the ISPN. And we've got more cases than that now. But at the moment, we are somewhere around 45 cases. But the important thing is we got a long follow-up. The median follow-up is more than 5 years. And the radiological follow-up is pretty important, nearly 10 years now. So what did we find? So of these patients, we have not had a single patient that we had to reoperate. So 100% of these patients had regression of the Chiari and deflation of the syrinx. When we looked at the patients who had posterior calvarial distraction, that was augmentation, it's fixed augmentation. This is distraction. So in the patients with distraction, we got over 100 patients, but 16 patients had significant Chiari and syringomyelia, which is roughly the statistics. About 20% of syndromic craniosynostosis will have Chiari and syringomyelia. In terms of the Chiari, the distraction resulted in 56% improvement, and 44% remain stable. That means that the operation ensured that nobody deteriorated. And in terms of the syrinx, 75% of the cases that were operated improved, the syrinx improved, and 25% are stable. And of course, it also depends on the length of the follow-up. What we also discovered that in some patients who already had a foramen magnum decompression and that it failed repeatedly, posterior calvarial augmentation results in a recovery. And I will show you a case of that. The ETV results, so patients who had a Chiari and syringomyelia that underwent ETV in our series. Again, these numbers are slightly out of date, but we are now just over. So then it was 10 cases, we had over 10 cases. And the percentage of success using the ETV success score was 90%, and currently is about 91.5%. So that is holding over a period of more than 5 years. So long-term follow-up results for Chiari syringomyelia with ETV are very good. These are the associations in these cases: achondroplasia, craniosynostosis, spina bifida, isolated Chiari. And you can see here that syrinx result in all the cases, and 90% for the Chiari. And this is the ETV success score for all of our ETV patients. Its overall is 82%. The predicted for our series was 71%, so we're doing slightly better. This is an example of a child with ventriculomegaly, Chiari, and syringomyelia. You can see quite clearly that there is large ventriculomegaly and associated syrinx and Chiari. So the first intent here was actually that, this kid needs an urgent foramen magnum decompression. It was quite symptomatic with Chiari-like headaches. But I resisted the temptation, actually did an ETV. After the ETV, so as I was way back in 2015, this child has continued to do well. You can see the preoperative scan and the postoperative scan. So this is 1 year post-op. The complete sort of regression of the Chiari and deflation of the syrinx is pretty impressive just with an ETV. So, and the scoliosis also got better. So you can see all of this is a syrinx and it's completely deflated just with the ETV. So I certainly, if you see outlet obstruction with ventriculomegaly, the floor of the third ventricle is depressed, ETV should be your first option. This is examples of the craniocervical junction fixation in Chiari malformation. So it sounds quite extraordinary that somebody would go and fix the craniocervical junction in the case of Chiari and syringomyelia and expect the Chiari to regress or the syrinx to deflate. And when I first heard of this from Professor Goel, I was incredulous and I really didn't believe it. But then I started looking at my series, and what I discovered is that there's a group of children who have basilar invagination with a simulation of atlas. And those children actually, when I performed occipital-cervical fixation, or in children who have no simulation of atlas, I would only do a C1, C2 distraction fixation. The distraction of C2 out of the foramen magnum results in improved CSF flow, and the Chiari and the syrinx improve. So I've now over 12 patients. Sorry, my apologies. That's the analyzed patients. We've got 16 patients now, and we've only had so far one failure where I had to take the patient back and do calvarial augmentation. And of course, there will be some patients that you can't operate from the back. In that case, a transoral odontoidectomy or occipital-cervical fixation, 360-degree surgery will be required. This is, of course, part of much wider algorithm we have for craniocervical junction deformities, but I won't discuss that today. Then I wanted to show you some examples of what I'm talking about. So here is a patient with Chiari syringomyelia. You can see that there's ventral compression by dolichoid dens, platybasia. This patient had basilar invagination with increased bris reflexes. You can see a syrinx. You can see the Chiari. And the way I go about doing this is I carefully do a CT scan, and we measure the angles which radiologically confirm the presence of platybasia and basilar invagination and its severity. So in this case, you can see that the basal angle is 142 degrees. The range is 104 to 129 in normality. But if it is more than 129 degrees, then this patient has basilar invagination. Bogart's angle is another angle that is constantly used. More than 135 degrees means basilar invagination and platybasia. And the Clivus canal angle, again, you can clearly see that this is going to obstruct CSF flow. So these three angles are used regularly to make the diagnosis of a patient that might benefit from a craniocervical junction fixation. And of course, all these patients have to have a degree of basilar invagination, and that is then measured across the Chamberlain's line and the tip of the odontoid. This patient actually adds not just occipital headaches and neurological dysfunction, but also had swallowing difficulties. And you can see that this patient now been operated, has had fixation. And the interesting thing is that her swallowing ability significantly improved following the fixation. And she stopped having microaspirations, and her condition improved both from the point of view of her voice, the tone of her voice, the swallowing, and resolution of headaches. This is another case. You can see here, sorry, my apologies. This is the same case. This is the original scan on my left side. At 14 months, you could see the syrinx disappeared. but there was still significant compression, and the Chiari looked pretty much where it was originally. But at 28 months, there's complete regression of the Chiari and syrinx. And we did not remove the foramen magnum. We just did a occipital-cervical fixation. So fixation does seem to improve the situation. And the other thing we found in this patient is that the patient had a retroodontoid mass. And after the fixation, the retroodontoid mass disappeared. And this seems to be supporting Professor Goel's theory of instability, because we know that in instability, you get this formation of the retroodontoid pannus. In rheumatoid arthritis, we called it, rheumatoid pannus. But I have seen this in patients with inflammatory disease. And interesting, the Chiari patients seem to have it as well. And after fixation, the retroodontoid mass disappears. This is another child with a Chiari herniation. You can see that the craniocervical junction is very tight. There was rapid progression. Can somebody silence, please? We can hear the conversation. Thank you. So again, I use the same angles, the basilar invagination, and then we carried out, in this case, there was no assimilation of atlas, so we did a C1, C2 fixation, and you can see the original Chiari on my left-hand side with signal change at C3, C4, so the Chiari was nearly at the level of C3, 4, and immediately following surgery, there was some improvement, and this is the MRI scan at 16 months with significant improvement by simple C1, C2 fixation. So I think that there is a role for craniocervical junction fixation. This is another child that had originally presented with craniosynostosis, which I had carried out an augmentation. Then the child actually presented with myelopathy, and I did an MRI scan that showed a significant horizontal subluxation and basilar invagination. The odontoid peg was inside the skull, compressing the brainstem. In this case, you can see the C1, C2 joints were vertical. So it's a typical case of, what you call a spinal anomaly, craniocervical junction anomaly with fusion of C1, C2 joints and so on. And this is a very difficult case, but we managed to do a C1, C2 fixation with occipital plates, and we managed to do a distraction of the odontoid peg. And you can see the postoperative appearance on my left-hand side, something like 15 or 16 millimeters of distraction. And look at the change. The Chiari is regressed and CSF flow is improved. So these are just some cases to show you the success of craniocervical junction in my series to regress Chiari and syringomyelia. Now, this is patients who have craniocephalic mismatch, no diagnosis of craniosynostosis, simple Chiari and syringomyelia. And what we carried out on them is a Calvary augmentation. You can see the signal artifact from the plates. And this is 5 years on. The Chiari is regressed. The syrinx completely disappeared. And I have case after case. As I said, we crossed over the 40 cases now for fixed augmentation. This is the child that I want to tell you that had initially undergone a foramen magnum decompression. So you can see the Chiari is quite significant, and the child was very symptomatic. We had initially actually offered augmentation, but the surgeon that was in charge of the patient preferred to do a foramen magnum decompression, and he did that. This is the first post-ops image. You can see a nice decompression, but the syrinx continued to progress, and the patient became more symptomatic. At the time, there was no scoliosis, so the patient then underwent a second procedure to try and release the obex and the foramen magendi, but all that happened is more of the cerebellum slumped downwards, and the child then developed scoliosis as well. And this is following the second craniovertebral decompression. You can see all the CSF now disappeared. The cerebellum is just slumping down with development of scoliosis. So at this point, I was asked to carry out the augmentation, which you can just see in the back here. And within 3 months of the surgery, you can see the improvement pretty much immediately with the deflation of the syrinx and regression of the tonsillar hernia. So I think one could say that both Chiari and Chiari I and Chiari II are herniations that are due to increase in intracranial content or a small relative cranium. So either craniocephalic mismatch or there is more brain than skull, and that in the presence of a large hernial orifice, the foramen magnum, this stuff will herniate down. And syringomyelia is a situation where the hernia is strangulated, allegorically speaking, and unless you do it, you create space, the syringomyelia is only going to get worse. So based on that, we developed this algorithm. And I'm really coming to the end now. If you have ventriculomegaly, you're going to get raised cranial pressure, supratentorial crowding, and that will lead to herniation, Chiari herniation, as I mentioned, and that will then cause a syringomyelia. And the same mechanism applies to craniosynostosis, where you get a small posterior fossa and craniocephalic mismatch, and to basilar invagination in craniocervical junction anomalies. Again, you're going to have a small posterior fossa and craniocephalic mismatch, and the end pathway is the same. There's another pathway where, in the presence of split cord malformations, lipomyelonmeningoceles, conus lipomas, scoliosis, you get a tethered cord and caudal pool, and you can get syringomyelia without a Chiari. In those cases, you can untether the spinal cord and the syringomyelia will get better. You don't have to do a foramen magnum decompression. So this is the holistic algorithm. But if you want to break this, you can see that there is Chiari and no Chiari. If there's a Chiari, you want to diagnostically characterize whether the Chiari is due to ventriculomegaly, craniosynostosis, or basilar invagination in craniocervical junction. If it is due to ventriculomegaly, our proposal usually is to do an ETV first and then monitor. If it fails, you can go back and do a calvario augmentation. If it is due to craniosynostosis, that means you're talking about a patient who has craniocephalic mismatch. It doesn't have to have a diagnosed single suture synostosis, but the features of a small posterior fossa, supratentorial calvarial crowding, then posterior calvarial augmentation is our recommendation. And in failed cases of ETV, you can do a posterior calvarial augmentation. I've done that successfully. And in case of scoliosis now, I do a posterior calvarial augmentation first, and more than 1/3 of the patients, the scoliosis improved such that the spinal surgeons decided not to operate on the patient. And in basilar invagination, craniocervical junction, I usually do a reduction of the invagination and fixation, ideally just with the C1, C2 fixation. But in case of a simulation of atlas, where the occiput is stuck to the atlas, either using the occipital plate or using the C1 makes no big difference. And this part I will leave behind because it's not part of today's talk. So I just wanted to conclude by saying, first of all, that the Chiari malformation is not a malformation, is a deformation. I referred to at the beginning of the talk about why do the cerebellar tonsils lengthen? The cerebellar tonsils lengthen because of external compression. It's like Play-Doh. They're becoming longer. They're not growing. And therefore, we should call it deformation rather than malformation. And the second thing is that the fact that the tonsils are herniating more and more means that there is an active dynamic process leading them to come down more and more. And for that, the explanation that is most likely to be right is supratentorial crowding or progressive ventriculomegaly. Both of those can cause that. And for those reasons, we then developed this algorithm where we specifically look for those three things and treat each one of those depending on which ones they are, rather than doing a foramen magnum decompression. And interestingly, the same things that cause a Chiari cause a syringomyelia, and therefore there's no need to treat the syringomyelia directly. Treat the cause, and the syringomyelia will get better. So my last slide, really, ventriculomegaly should be treated first by ETV. Hindbrain hernia progression is partly due to supratentorial crowding, and a posterior calvarial augmentation by any means is what one would recommend. And in cases where there is basilar invagination and instability, please do a fixation. You'll be rewarded with a very good result. And of course, in the distal syringomyelia, take the lipoma out. Thank you so much. and I appreciate your time.
Thank you. Thank you very much, Girish. Are you hearing me?
Yes, we can hear you well, Professor
Okay.
Salomão.
Okay. Thank you.
We can hear you very well.
We can move to the questions and answers. If there is someone who want to put a question directly, now it's the right time. After this, we'll go to the questions and answers that were posted at the site. Okay? Do you want to make some question or comments about the session?
So let's see. There's one question in the Q&A that pertains to intrauterine surgery and its impact on the Chiari malformation, which of course would be the Chiari II. So would any of the speakers like to comment on that? But please limit your comments to about 20 seconds so that others can comment as well, please.
Yes,
okay,
so
please.
thank you. I was just going to answer. We know that in children fetal surgery, there's a reduction in Chiari II development after the repair of the myelomeningocele. And something like 35% of the children are born without Chiari II. But even those that may still have Chiari II, Samir Al-Baba shared some images with me, and he's presented several times his work on doing ETVs. Just like, I do the ETVs for Chiari I, he has been doing ETVs for Chiari II with equal success. So he has been able to reduce the frequency of shunting these patients by something like half, or 40 to 50%.
Great comment, Girish. That's great. Other speakers, comments on intrauterine surgery and Chiari II. Comments.
There are some questions here at the QA from Nazira Alana Ziroro. Good day, thank you for the very interesting and useful presentation. Is there any data on outcome of intrauterine surgery for this pathology? Any answer?
Well, any of the other speakers want to comment? I think that was one of the big benefits, right, in the original MOMS trial, was a very profound reduction of the extent of Chiari II, right? That was one of the primary outcome benefits of intrauterine surgery, and it has carried over regardless of the technique, right? Recall, now there are multiple techniques for intrauterine surgery, right? There are the open technique, the fetal closure, where the fetus is rotated. There is the endoscopic technique with a variety of different variants, but they have all carried over and shown a substantial reduction, and some would even say almost, dare I say, elimination of the Chiari II, and that's probably the biggest single contribution. The shunt rate or CSF treatment rate has reduced, but that's a less solid outcome than the Chiari II outcome.
And then just shortly to say that on the cases of intrauterine hydrocephalus and that cause tonsillar herniation, probably we need to follow on fetal treatment. We need to follow up on the results of the Sao Paulo, Brazil group where they're treating hydrocephalus in utero, but those results are just coming up.
Thank you for that comment, Zulma, because that's important. And I would just tell the participants of the webinar that next month is going to be spinal injury, but then the month after that, which I think we're up to April, will be fetal surgery. So we want to encourage everybody to attend that one. Now, we started 5 minutes late, so I think it's reasonable to go 5 minutes over. And I don't see other questions. Professor Salomão, I didn't see other questions. Artur, did you want to present your case? You had a lovely case to potentially discuss.
No, I would like to. I'd like to put a question for the audience. We're talking about several strategies in surgical management of Chiari I and Chiari II, and just little words about the other kinds of other Chiari forms. But I'd like to ask, that's a very provocative question, about the surgical management of Chiari with section of the filum terminale. Do any of the speaker or anyone from the audience had any experience about it?
I don't have any experience with section of the filum terminalis in the treatment of Chiari, symptomatic Chiari malformation, yes?
Yes, me too.
I think that's a controversial point. And that's why I routinely in patients with Chiari do an MRI lumbar before offering surgery, just to rule out that there is a polyneurotheter cord. I have patients that have actually both of them, and it's my practice to perform the antethering before I offer any surgery for Chiari. But I know one of the speakers talk about it and say that so this is a point of controversy. But it's very interesting. Usually my practice is to do the antethering first and then follow up on what happens with the Chiari afterwards and the Chiari symptoms.
Okay, thank you. There is one.
Thanks. Yeah.
Thank you, there is a last question that went from Juan Miguel Alemán, who he want to know about dynamic radiographies in case of atrial to axial instability. No more questions? Yes,
yeah.
please do it.
Yeah, so X-rays are very difficult to do in children to test this sort of instability. I think the common example is children with Down syndrome. They have orthodontoidium. They often present with atlantoaxial instability, and you can diagnose that. But otherwise, they're not very helpful. And you often, in Chiari, what you want to find is whether there's CSF present during flexion extension. And then you're talking about complex CSF signal MRI scans in flexion extension, which the radiologists get very anxious. I try not to use them in my experience, apart from the very basic necessities. I don't know what the other colleagues do.
Okay.
I think Kaushik want to say something.
No, I agree with Girish that it's very difficult to take a small child to do a dynamic
Lean in, Kaushik. Can't hear you. Lean in a little.
No. It's very difficult to do a dynamic scan in a small young child, but in a little bit older children or adults, we can always ask for a dynamic scan and should do that. Because the MRI is not at all reliable to outline the associated body abnormalities, and should be a part of our clinical practice regularly.
Absolutely. I agree 100% with that statement. And that's precisely what I meant. Yeah. Can I give a comment on the phylum?
Oh, yeah.
And Chiari?
Please do it.
I'm itching to say something. Well, so I have lots of patients in the UK that go to Barcelona and they pay more than £10,000 to have an untethering of the spinal cord for quite extensive Chiaris and syringomyelia. And of course, the concern here is that there is no foundation for such treatment. The phylum embryologically arises from the remnants of the notochord at the corners, and they exit in the sacral region, and the surgery is extradural by releasing the extradural portion of the phylum. Now, one of the important things that I should comment is that in Chiari, the herniation is of the cerebellar tonsils, which is not part of the brainstem. And the herniation is completely separate from the brainstem. So how is the change, even if we imagine that the brainstem moved up, that's not moving up the cerebellum. The cerebellum is pushed down, as I mentioned, by small posterior fossa, the tilting of the tentorium and the supratentorial crowding. That's what's pushing the cerebellum progressively down. And untethering the phylum, in my opinion, would not improve the complex Chiaris. Now, I've not performed an untethering of spinal cord for complex Chiaris. I know other surgeons have done, but I also, just like Zulma, if somebody comes to me, I do a full MRI of the spine, and if there is a fatty phylum and a tethered cord, that's the first procedure that I would do, because some of these patients also have scoliosis, they have syringomyelia, and untethering the spinal cord results in a deflation of the distal syrinx. So it's a procedure that I would definitely do first before attempting anything else.
And I think that needs to be probably our last word, because as we can tell from the conversation today, Chiari remains a topic of considerable interest, of great variance from center to center, with many centers reporting good outcomes from different interventions. It's clear for the listeners that this is a dynamic entity, that cerebrospinal fluid dynamics are central to it, that one needs to consider both the neurologic elements and the bony elements with regard to fixation and basilar invagination, and that the questions will continue. The only caution I might add as a distant observer, having been involved in training a lot of people, but not specifically in the Chiari pool, if you will, great caution needs to be taken in opening the dura whenever a posterior fossa decompression is done in Chiari II. It is not at all uncommon for the tentorium to drop and the torcula to be much larger. And there are in every center cases of individuals well-intended wandering into the torcula, and that can be fatal, okay? So great care if you wish to decompress Chiari II malformations, and that's a whole nother conversation topic. But great care there, please, so that none of the participants of this webinar ever have that catastrophic complication of a torcular intrusion with massive bleeding from not recognizing that. I want to thank very much my partner, Artur, in coordinating a fantastic webinar. We've heard the wide breadth by which Chiari is treated. We want to thank Professor Salomão for being an extraordinary moderator. It brings the voice of decades of thought and experience to this, to our individually faculty members for thoughtful, substantive, colorful presentations, but most of all to the participants today for attending the webinar. There are MCQs that will be posted by Linda. You can see it in the chat right now. She just put it up. She said you may complete today's MCQs here to get proper credit for participation. We thank the participants. We look forward to seeing you next month, and we strongly welcome and encourage you to join ISPN in the interim. Artur, I'll turn it to you for closing words with my gratitude for putting together such a wonderful session.
Yeah, okay. So thank you everyone who joined us for this webinar. Thank you to the expert who brought their knowledge and experience to such an interesting topic. We have a webinar every month, and we hope to always have your presence. And finally, our message, join us and be a member of ISPN. Thank you so much.
Bye.
Bye-bye, everyone. Thank you.
Bye-bye.
Thank you, everybody.
Thank you.
Bye.
Thank you. Bye.